I am licensed in Pennsylvania. I want to be clear that what I'm talking about today, as always, even if I am your doctor, is not direct medical advice. Please talk to your doctor, whether it's me or someone else. I'm going to try to be really fair with what I talk about today, as I always do. This is meant to inform,
It, Dr. Danielewicz, there's a there's a
if
pretty bad
everyone could
echo.
please mute, that would be you got it. Thank you. Sorry. Gotta love it. So now, of course, whatever I just did stopped my presentation. Give me 1 second here, all. So, medical aid in dying, you will hear this described a number of different ways. You're going to hear the phrases death with dignity. You're going to hear right to die. You are going to hear a couple of phrases that have fallen out of favor, one of which is called physician-assisted suicide. You may hear the phrase euthanasia, which is related, though somewhat different. And the reason why a lot of the groups that are involved in this and the researchers who study this have focused on medical aid in dying as the topic or as the title is because it is the one, if you think about any of those other words that I just used, a lot of them carrying a certain judgment, whether positive or negative. Medical aid in dying, as it is defined here in the United States, typically requires that one have a terminal illness. Generally, in this country, that is thought of as a reasonable prognosis of 6 months or less. We are, in medicine, terrible at prognosticating as a global group, meaning we do not always know exactly when one has a 6-month prognosis or less. We use a variety of tools. We use our clinical decision making. When we are thinking about medical aid in dying as it is commonly done, the physician, and it is often a physician, ordering medications, but the patient themselves must administer the medicines. Meaning, you must have the ability to take the pills and either put them through your mouth or put them into an artificial feeding tube. Other people cannot be giving these medicines to you. They can hand them to you, but you must take them yourself. Euthanasia is related but different. It is often done in the situation of terminal illness. Yes, not necessarily with that same 6-month or less prognosis. There are some other reasons why one may consider euthanasia. The common definitions, and I'm going to talk about what euthanasia is, the common definitions are irrevocable suffering, suffering that is not going to end, or at least we think it's not going to end. Euthanasia, good death, the act of causing a good death, is a more active process. This is the process of someone else putting a chain of events into action that results in the death of the patient. This can involve a family member pushing IV medicines via a pump. This can involve a physician directly administering medicines. In an example I will give you out of a very controversial device in Switzerland, it can involve a device programmed to deliver said medications. So these are important distinctions. The idea of medical aid in dying is also the one that is known as physician-assisted suicide, that term has fallen out of favor, is a process that the patient has to partake in themselves. Euthanasia, another person is directly involved at its most basic. There are right now in the US 10 states in which medical aid in dying is authorized. You can see those here. Pennsylvania, as you can see, the light blue states are where medical aid in dying is currently legal. Pennsylvania is not one of those states. Pennsylvania has made attempts over multiple legislative sessions to bring medical aid in dying legislation through both the House and the Senate. It has come up, I think, at least twice, and if I'm remembering correctly, 3 times. Most recently in 2024. Every time it comes up in Pennsylvania, it has not made it out of committee. meaning it has never come up for a vote on the floor of the House or Senate in Pennsylvania. New Jersey, our neighbors across the river, where I'm from, it is legal, although I'm going to put a big asterisk next to legal, because even though it is available in New Jersey, as of, well, now, there is only one group that is actually doing it in the entire state. This map does not show the legal challenges to medical aid in dying. In many states, including New Jersey, there are significant drives from a legislative perspective to curtail this, to bring it back, often led by groups that have religious, moral, ethical concerns about this. Now, what about euthanasia in the United States? Nowhere. Nowhere in the US is euthanasia legal. It is actually explicitly illegal, including in all 10 of those states that allow for medical aid in dying. And as somebody who has studied public health, as somebody, that's my background degree is in public health, with an interest in health policy, the idea of euthanasia ever coming to the United States of America is something that politically I would be shocked if any of us see it in our lifetimes. It is considered a politically unfeasible thing in the United States, and there are a number of really interesting arguments as to why it should remain that way. We are going to get there throughout this talk. Euthanasia, this idea of a more active process that other people are involved in. The criteria for qualification are going to vary depending on where it is available. Like I said, there's this idea of terminal illness or unbearable suffering. It is permitted in a variety of European countries. Interestingly enough, you will not see Switzerland on that list. We're going to come back to Switzerland. It is permitted in Canada with certain limitations in parts of South America and in Oceania or Australia, the Australian subcontinent. When we expand our criteria for euthanasia to involve unbearable suffering, the big question that comes up again and again, and the Netherlands has an answer to this that's very definitive, is do we as a medical community include psychiatric diagnoses or psychiatric illnesses in the realm of unbearable suffering? Now, euthanasia is illegal in the US. Just to be clear, even if it were not medical legally with the way that we treat mental illness in this country, it would never be considered part of that. The Netherlands have a very different approach. We're going to talk about that in just a minute. Before, I want to backtrack and I want to talk about what does medical aid in dying look like here in this area. If you're in Pennsylvania and this is something that you are at all thinking about, and again, not encouraging it, not discouraging it, it is not legal to do that in Pennsylvania. You will not find a medical provider who is willing to do it legally. And so the question that some people were bringing up before, well, do I have to go across the bridge? The answer is if you were seeking it, yes, but also you would have to live across the bridge. All states in the US currently that allow medical aid in dying, that act of a doctor prescribing medicines to bring about end of life in serious illness, require that you are a resident of that state, which can be really complicated. New Jersey's criteria are fairly similar to those in other states. You have to be over the age of 18. You have to have that terminal diagnosis with a prognosis of 6 months or less, at least reasonably determined. You have to have the cognitive ability to be making this decision. There are these concepts in medicine. One is called capacity. Capacity is the ability to logically reason through a decision, the ability to understand the benefits, the downsides, and make an informed choice. So you have to be capacitated to make this decision. Capacity is a moving target, meaning people can have capacity to make certain decisions and not others. Capacity can fluctuate. It can change from Hopefully not, it can change from minute to minute. In this case, we want capacity over time. As I said here, you have to be a New Jersey resident. And the residency requirements in New Jersey are not that strict. You have to basically be domiciled in New Jersey for greater than a year, or for greater than half of a year to be considered a New Jersey resident. You must, as I said, be able to self-administer medicines. Others may hand you the medicines. People are not allowed to guide things into your mouth or into a feeding tube. And you must obviously be acting voluntarily. That is a prerequisite for any of these programs for medical aid in dying. So people then ask, well, what does the process look like? And part one of the process is finding a physician or a physician group that is going to be willing to work on this with you. So let's assume now one has this chronic, life-limiting, not even chronic, they have a life-limiting illness. The prognosis is reasonable, falls within all of these criteria. You have to find a group that is willing to provide these medicines. And I will say in the first years when this first came up in New Jersey, this was not easy for people to do. To this day, there is one specific group called Compassionate Endings, which is very interesting. Just an interesting name, that continues to do this. You then need to provide, on separate occasions, 3 requests to a physician. 2 verbally, not on the same day, separated by a time. They don't say how much time, but it cannot be on the same day. And 1 in writing. Your physician then has to review that request. And the law is very specific that if at any point in this process, there is concern for capacity or fluctuating decision-making, or coercion, you are required at that point to involve mental health support, but they don't specify if it has to be psychiatrist, psychologist, behavioral health consultant. Prescriptions for these medicines cannot be paper scripts, as anybody who knows this now, are not very much a thing in medicine anymore. Jefferson itself just stopped issuing paper scripts entirely about a year ago. Medications, for those who still do have the team that provides a paper script, cannot be handed to you on a paper prescription and carried out. Things have to be directly furnished to the pharmacy. By law, those medicines, as I've said about 5 times now, have to be self-administered. New Jersey law is very specific in trying to prevent any issues with insurance or with any legality, that the cause of death on the death certificate is to be noted as the underlying disease process. The Jersey law is very specific that in this situation, a death that is a result of medical aid in dying is considered attributable to the primary diagnosis and not considered a suicide or homicide by state criteria. Yes?
If 2 of them are verbal, how do you have proof that they were actually verbal?
It would have to be, the physician would have to record it in their note.
Oh, okay.
Yeah. And the group, I will say, that does this has a very systematic way of doing it. Other questions about Jersey? Yeah?
I've always been baffled by this. When my mother was dying, they call it palliative care, and it's supposed to be compassionate care, but they're giving you morphine, and they want to take liquids away and everything.
Yeah.
But the end result is really the same. And they're still helping the person pass on. So I'm a little confused of what the interpretation is.
So there. Well. So here, both of those are really good points that, and again, I do hospice, so this is a question I get a lot. There is in hospice, and so for those, let's back up for a second, because this is worth a little diversion. Hospice care is care that is focused on comfort at end of life. End of life being, we reasonably assume that 6-month or less prognosis. Comfort being relief of symptoms, pain, nausea, vomiting, anxiety, shortness of breath, agitation. This is truly the feel I give people on hospice. Hospice does give medicines that can be strong in some ways. We give medicines for those things, for those symptoms. We give opioids like morphine for pain. We give medicines for anxiety like benzodiazepines. Ativan is the common one, lorazepam. Those medicines, in many cases, people have heard of and people are scared of. The idea is, well, are we speeding up a natural process? And the answer from the hospice side, and this is not just, I'm going to be honest, it's not just BS, this is actually how it works, is we rely on this foundational principle called the principle of double effect. Meaning, we know that these medicines are strong. We know that the people, if we are appropriately selecting folks for hospice, which we should be, have an illness that is time limited. We are not intentionally trying with hospice to speed up a natural process. We are recognizing that the disease process is ongoing, that we have to treat these symptoms, and we have to balance those two. The idea of restricting things like fluid or food intake is based more, not so much on hurry up and make this happen, more in terms of what does the body do as it is transitioning, as it is shutting down? What does the body do with those liquids? Because the reality is the human body often sends those liquids to the wrong place. You will see fluid accumulate in lungs, because as the body is transitioning, nearing the end of life, the body does not necessarily know what to do with nutrition. So whenever we say we recommend not giving fluids or we recommend not doing this, it's not with the idea of, okay, let's move this along. It is with the idea of, let's try to minimize those potential symptoms. We give those medicines at the same time, and it can really feel, especially when I see folks in a hospice inpatient unit, where folks come in, sometimes the process happens fairly quickly. By the time they reach us on hospice, folks have often been through a lot. The body, I always say, can do a lot of things, but it can only handle so much of the stress of serious illness and so much of the stress of the many, many things that medicine can and often has done to folks by the time they reach us. So I hope that kind of brings it together. The idea of hospice is different from this in that our goal is not to speed things along. Our goal is to provide symptom relief. And we're going to talk in a few minutes about how hospice approaches these sorts of requests and also how the societies do. I will say, as a federal benefit, hospice right now in the US is very separate from these state laws. There is no federal prohibition on medical aid in dying necessarily, but the federal government in general says, we leave that to the states, we are not getting involved in this. And that's admittedly, if for people who want this to continue, probably a good thing right now. Does that get to where you were hoping it would?
Yes. But yeah, one more question.
Yeah, please.
What's the difference between palliative and hospice?
Aha, good question. Hospice care is care that is, we reasonably look at a patient and we say, based on your medical condition, we can assume that your prognosis by federal standards is 6 months or less. Now, those are often very life-limiting conditions. Very advanced cancer, advanced heart failure, advanced lung disease are the three most common. There are a variety of other qualifying. One can qualify for hospice with almost any diagnosis. Big asterisk on that, we'll come back to it. Palliative care. If you think about the greater umbrella, palliative care fits over everything we're talking about. From this to hospice, palliative care is a greater umbrella, where palliative care relies on symptom management, a lot of the same symptoms as hospice, in serious illness. Palliative care does not require that one has a terminal prognosis of 6 months or less. We actually, these days, are encouraging, and this is a good thing, palliative care to get involved in folks' care earlier in the disease process. One of our outpatient clinics in my second division, the Division of Palliative Medicine at Jefferson, is working very closely with our lung specialists, pulmonologists, and our cardiologists or heart specialists, knowing that certain conditions, congestive heart failure, interstitial lung disease, even when we are still going for best medical therapy, have a lot of symptom burden. Palliative care can be done alongside what we call attempts at restorative medical therapy. Meaning, one can be under the care of a palliative care doctor for their heart failure and still be admitted to a hospital, placed in the ICU, get all kinds of intensive care. Hospice is a down the line thing, or not down the line, that's the wrong. It's not linear necessarily. Hospice is a different way of caring for folks, really thinking we are nearing the end of life. We're going to shift away from looking at all those intense poking, prodding, ICU stays. We're going to focus exclusively on comfort. So I think about palliative as running alongside the rest of care, hospice really taking everything on and looking exclusively at comfort. I saw a question here, got a question or a comment.
Where does, like, if you're on hospice and you have a defibrillator, for instance?
Yeah.
Do you think to turn it off then or not turn it off then?
Yeah. It's a great question. It is a really good question. So when we do intakes for hospice, this comes up all the time. It is often, to back it up even a step further, we talk a lot about code status in medicine. What happens if one's heart stops or if they're unable to breathe? Do we do chest compressions? Do we do a ventilator? That's the big question. Technically, for home hospice, being full code and wanting those things is not an absolute barrier to being on home hospice. Big caveat there. Do I recommend it? No. Yeah, I do think of it as, I don't think of it as being fully in line. When it comes to things like a defibrillator or other forms of artificial life support, we have very individualized discussions with people about that. And we say, is this benefiting you symptomatically? Meaning, if that defibrillator goes off, is it just going to shock you and you go back to a normal life? Or is it going to go off 5, 6, 7 times a day and cause you extreme stress? These are things that a good hospice team is going to continuously evaluate. The one exception to these questions is when we bring folks into what's called a hospice inpatient unit. We did a hospice talk, I think 2 years ago, but I want to give this basic thing. Hospice. People tend to think about hospice as a place. And the reality is hospice is a style of care as opposed to a place. The vast majority in this country of hospice occurs in the home, greater than 90%, over 95 actually. When we think about what we're managing at home, sometimes it is just too much to handle at home. We can't get people comfortable, we can't manage symptoms. That's when we look to these inpatient hospice units. There are only 2 in Philadelphia now. When I started here 9 years ago, there were 12. They are closing rapidly.
Wow. Why?
Profit. They're not profitable. Yep. They are not, they don't make money. Oh yes, it is. When we bring people into the inpatient hospice unit, those are places where we do have the discussion about, we do not do CPR in those units. We do, if you are to come into those units, we do deactivate the defibrillator. That's the sort of hard stop to come into one of those units. Does that answer your question?
Yes, thank you.
We had another comment here.
How do you hear about palliative versus,
Yeah.
are these are separate groups then?
Yes. Well, sometimes some groups will do both. Some are separate.
Okay.
In philosophy of care, they are similar. But if we want to think about palliative, can occur alongside your other medical treatment, like you continue to see your specialists. If you need to be in the hospital, you go to the hospital.
But what would cause you to invoke palliative care?
To choose palliative would be symptom burden. If you are trying to get more comfortable while also managing these symptoms.
Gotcha.
Shortness of breath is a big one. Anxiety is another big one that we manage in palliative care.
Okay.
How hard is it to transfer from the home palliative care to, say, one of the?
It's a good question. Like a facility. Good question. So let's say you are on home palliative care and things are not, we use a lot of phrases, I call them hope and worry phrases in hospice. I mean, in palliative medicine. So even I do it. When we are treating someone, I always hope that things improve, and I worry sometimes that they may not. So let's say in this case, we're treating someone at home with home palliative care. They're going to their specialist, things just aren't improving. We make that switch over to hospice, knowing that going back to your cardiologist, pulmonologist, oncologist is not helping at this point. The point at which we look at transfer to one of those inpatient units is if the symptom burden becomes too much to manage at home. When we are managing that shortness of breath, and despite, remember, home hospice, or note home hospice, your own support network, whether it's family, friends, or in some cases the patient themselves, is administering those medicines. And if things just are not working out, if we're not controlling symptoms, having uncontrolled pain, breakthrough shortness of breath, that's the moment when we invoke needing to go to the unit.
Who makes that kind of decision?
So that would be you have contact with the hospice provider and they help set it up.
What if you're incapable of administering medications to yourself?
Unfortunately, a common situation that our
Are
healthcare.
robots gonna take this over, or
What's that?
are robots gonna take this?
No, not yet, although they do keep trying to put robots into everything in medicine. The third place that hospice can take place is within skilled nursing facilities. So for folks who need that level of care, it often involves placement in a long-term care facility. If folks either can't give the medicines themselves, or if their support network is not able to do that. Admittedly, when I'm on consults next week at Jefferson, I guarantee I will see at least 2 to 3 situations like that. And it is one of the many.
Doctor actually gives you the medicine.
It would be one of the nurse or staff. Yeah, it's hard, and it's not always done well. I'm gonna be honest.
That's kill you badly?
What's that?
They kill you badly?
I wouldn't say. The one thing, I'm not one of those people who's on people about language, but I will say hospice does not kill people. The primary condition is what is behind everything. Meaning, we're not trying to kill people, just to be clear.
Is this the usual method, morphine?
Morphine is the most common medicine, and I'm okay with this diversion. Morphine is the most common medicine used in hospice for pain and shortness of breath.
Right.
It is widely available, and it is available in a liquid that can become very heavily concentrated.
Okay.
Meaning, folks at home aren't usually walking around with IV. Sometimes people don't have the ability to take pills, and so having a medicine that is a very small droplet that can get absorbed right in the mouth is very helpful.
For the internal.
think we might have lost them. Let me text Ed. They will be back shortly. I don't know what happened. They somehow got booted off, but they'll be back. They're working on it.
It's those times when if you're the host, sweat is on your brow, you know.
Say that again. I forgot I had my headphones
Oh,
on.
yeah, it's if you're the presenter or the host and the sweat is coming down, you know, like, oh my God, oh my God, oh my God.
I know, I know. It sounds like I was afraid that maybe their laptop died, but it sounds like the computer is still working. It's just a Zoom
Oh,
issue. So
connection, yeah, connection goes.
yeah, the Wi-Fi over at John C. Anderson can be a little shaky. So maybe that's what's going on. So how's everybody doing today while we while we wait?
Yes, I was do hand puppets like
Yeah,
back in the day, right? I'm okay.
nice. Happy to hear.
In some ways uh, uh, related to the topic. And this is kind of going into a dark place, but you know, it's like, well,
Hmm.
it's sick, you know, I mean, you have to go with,
Hmm.
you know, like, well, gee, maybe there is a ultimate benefit with fentanyl, you know. I mean, this I don't know
Yeah, I
what the
mean,
dose is. And my fear would be, you know, like you try and it doesn't work. You know, you don't go, you don't die, you know,
mm,
and be like, oh shit.
it's very is it Little Miss Sunshine, right? That's the the plot with the grandfather in that
Yeah,
movie.
I don't know. But yeah, like, you know, what if this doesn't work?
Mm,
Or you think it's gonna work, but it doesn't.
mm,
I know it's a tough subject.
yeah, but I think yeah, I think you know, to your point though, it's interesting and there's like a lot to be um unpacked, right? Even if it's you know, can be difficult to work through.
Mhm.
Yeah, I think this originally had come up as it might have been a part of that hospice conversation that he referenced in
Mhm.
a previous meeting of
Right.
ours.
Yeah.
And I think it like really kind of snowballed into its own kind of full-fledged
Mhm.
conversation, and we put a pin in it to say like, oh, this should be its own, you know,
Yeah.
full
Good.
full discussion.
It's well, maybe not.
Or at least a half a discussion, maybe.
I could do it next month or 2 months from now or whatever the frequency is.
Yeah. Well, while we're here, I'll give you all a rundown of our
Oh,
topics for the month or for the year, for the next few months for doctors. And so this month is medical aid in dying. All right. Next month is going to be longevity and healthy aging. Um, May is going to be a discussion on the changing policy around Medicaid, SNAP, Medicare, the Affordable Care Act, Marketplace, like all of the
oh boy.
there's a lot going on there. So I think yeah, some updates and some, you know, kind of wading through that. I didn't know that he had went to school for healthcare policy, so I'm sure he'll have a lot to say about that. And then in June we'll be discussing Alzheimer's and dementia. And then in July we take a little break for the summer.
They're good.
Yeah, I think we have a good
And
selection of stuff.
it always helps, at least in my opinion, it always helps because you know there's so much garbage out there and you know hearing it from number one, someone local, and one of us, and
Mm,
cognizant of things that are, you know, can be unique, but not necessarily being unique, being gay or
yeah,
bisexual,
yeah.
whatever.
Like even if it's
Different
not,
relationships, although it can be applicable to others, but yet,
yeah, like even if it's not like an LGBT topic, having it presented in a way that is like, from one of us, from
Mhm.
family,
Mhm,
or
mhm,
or
mhm.
like with an understanding of how it, might be, our experiences might be different, or whatever is,
Exactly,
yeah, makes a difference.
exactly.
Yeah. I will also remind folks, if anybody is available tomorrow afternoon, we are having our monthly grocery day
Oh,
at the church. So if anybody would like some free groceries, I actually just picked up a bunch of stuff this morning for us. So you should have a good selection this month. And that's at the church from 12 to 1:30
mm.
tomorrow.
Sorry, I haven't been much of a participant in person
Yeah, that's fine.
since
There's no,
since the beginning of the month. I've had things that happen, and then like Tuesday's the only day available,
mm,
for something. And thing.
yeah, I
Usually,
get, I get how that
usually it's
goes.
more like Tuesday's my. It's like where I'm hearing my mom, well, older women saying, "Oh, I can't do Tuesday.
Yeah,
that's my story day," or something like that. And but yeah, so unfortunately, like
okay.
unforeseen dental work that needs to be
Uh,
done.
well, as it so happens, we are meeting on Wednesday next week.
So,
And I feel like I have a captive audience, so I'm just kind of
I
plugging all
was gonna say, where'd everybody
the
go?
stuff I have going on. So yeah, we're taking a trip to the Institute of Contemporary Art next
Oh,
Wednesday. Um,
I remember.
so
Oh yeah, I remember seeing that. I think in emails. I think
yeah,
down below, which is always good because you can always plan ahead. Right?
yeah. So I think it'll be a nice little trip. We're going to see an exhibition about the Shakers and Shaker furniture.
Hmm.
And then there's this other exhibition. Zenobia Bailey is the artist. It's called Entryways. And it's like a futurist textile exhibition. That I think sounds pretty cool.
Oh.
So we're getting a tour of both of those.
Check the progress here.
So Ed
Mhm.
said, internet is not connecting, still
Ooh,
trying.
ooh. Yeah, when I've encountered this at home, I mean, I've even had where the extreme is where you're literally power off everything and then power back up, but that's probably not doable in certain situations, And there could be
Yeah.
micro power drops. It could be the service provider. It could be anywhere.
Yeah, I'm surprised. It's usually in our office back in that building that the
Mm.
internet drops out so bad, but this in the
Or
community room over there, it's usually not so bad.
we could attribute it to a plot, a conspiracy.
It is. It's yeah, from lobbying groups who don't want
Yes,
people to know about
yes, yes,
medical aid and
yes.
dying.
Yes, 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 yes. Well, it has to be at least 20 years now. The whole circus surrounding Terry Schiavo,
Mm,
um,
yeah, I remember that.
and where, the you could tell at that point, and again, going from a political standpoint, because everything anymore now, anything becomes a political football. Um, where, oh, all of a sudden at the time, the Republicans who were like, get government out of our lives, became, let's get government into your lives.
Mm,
Because they were, and
yeah,
we'll stop there.
yeah. There was, I think in Atlanta, there was just a case where this woman was, again, not to be grim, but this woman was brain dead and was pregnant. And there's this whole
Mhm.
discussion about like
Exactly. What do you do?
the right to die stuff
Exactly.
versus this like, um, fetus, unborn child, and they forced her family to like carry the child to term. Um, yeah, it was like a whole
Yeah,
thing.
what we would normally think of a family within family personal decision becomes a
Yes,
public.
a whole political
Yes, and
thing.
then when
Yeah,
politics gets involved, then it's a circus, and it never goes back into the bottle. It
yeah,
just, and unfortunately, families like now what?
yeah, yeah. It's ongoing.
The whole personal choice, but anyway.
Yeah, well, yeah. Apologies to the group for
Well,
this intermission that we're having. See, Ed is typing a message, so maybe there's going to be an update.
they could do it in person, and then they can revisit some other place some other time.
Yeah, if they end up not being able to connect, I can I can definitely send the PowerPoint. Actually, I can, you know what? I can send it to you. I can put it in the chat right now for us all because he sent it over to us this morning. So I will do that now just so that we all have it. Do, do, do. Okay. All right, cool. So yeah, so for all in the chat, I just sent the PowerPoint that the doctor is using today for our
Yes.
presentation.
Okay.
So if for whatever reason they don't make it back on, we have access to this. You have access to the
Got it.
slides here for the rest of the presentation.
And most likely probably won't.
It seems like there's a good chance we might not get to see the rest of the show, but
It's sort of like let's see if it actually came. I know I pulled it in, but let me go to where I saved it and see what
okay.
pops. Uh, Oh, yes. Good. Looks like what are we? I forget
Yeah,
how many slides. 15 slides total.
15. So yeah, where did this saved it to my desktop, but I'm not seeing it. Disappeared.
Oops. I've got 15 slides. The last two, one is a
There it is.
discussion, and the other one is just Jefferson. There's one. It might have been. This might be like a YouTube, maybe not. It's CBS Evening News, but that's all right. Fine, I'll find.
Okay.
All right, good. Well, thank you.
Yeah. I was gonna see. I can do this.
Share, yeah.
Yeah, I can I can share us through the last where were we?
I'm not so and so when I play him on TV. I think he ended up. I forget where it was. Yeah, but that's fine. That's good.
Okay, so yeah, so we have these.
I think
Okay, so
that's
yeah,
where
so
we that's where we
yeah,
were. Yeah, the
okay,
New Jersey example. Yeah,
okay, so we were here.
and then to go in
Let's
there.
see.
Oh, that's
Okay, so this is sort of the looks like the process of how you might make a request. Should you be
got
a
it. Yeah.
New Jersey resident?
Yeah.
Distant
Yeah.
example.
He's going to talk about
Netherlands.
Netherlands. Yeah.
Okay. If you're oh, If you're over 12, between 12 and 15, wow. Between parental consent or with parental consent, initiated by patient. Okay. With, yeah, if
All
the
kinds of,
physician is satisfied
right.
with these
That's,
circumstances. Okay. Um,
uh, and rightfully so. It's not a like, okay, let's just go out and buy a gun, you know.
yeah,
I mean, it's there is because when you think about it, the end result is it's final. You're not coming back.
yeah.
No, at least
Do you want to,
that's my lay opinion. So I'll
yes,
stay with
yeah,
that.
yeah. You want to make sure you have, right, like a fully informed
Exactly.
decision.
Especially if your physical condition and or your that yeah, um, you can't make a decision or you don't have the ability because I mean, let's face it, there have been times where just having the flu and you're feeling like, uh,
You said this is it.
yeah, this is it, when actually it's not. And so, anyway, well, at least from my perspective, that number one, thanks for forwarding that off. Um,
Sure.
I have a
Do you want
feeling that
to?
I have a feeling that they probably won't.
Ed texted me and I just told him not to worry about it. And
Right.
we're chatting here. Do you want to, before we in our little group wrap it up, do you want to watch this video, the CBS video?
I think I'll watch on my own.
Okay.
I mean, personally, for me,
Yeah.
I will, because what I'll
How
do.
about yeah, the rest of the group, do you have strong feelings about the video? This is yeah, feel free to shout them out. All right. So why don't I will leave the video to you all to look up on your own, and maybe we just call it here for the
Yep.
day.
Very
Cool.
good. Good.
All right. I'm gonna stop
Hey,
recording now.
what's